Hello, my dear candidates. How are you all? Hoping all are doing well. First of all, I want to be ensure is that my voice is clear, my dear candidates.
Yes, ma'am.
Yeah,
Okay,
yes, ma'am.
thank you, Ratna.
Yeah.
Yeah, thank you. Today discussion will be the ECG related question and also few cardiology related question. As I always and every day actually same dialogue I will tell every day because till now my fifth batch ongoing, but who follow my advice strongly, I'm sure they'll never do wrong because many feedback I'm getting every day. My sources, my materials, it could be huge, but your preparation will not be huge. Because why? Because you already on the course. My instruction you have to follow. I didn't give the access regarding the PDF protocol like step by step, medicine, chapter wise PDF, gynecology, pediatric. I didn't give still. Of course, every day of my session, I'll give the PDF. This is the course value. But few exam candidates, exam very near, they fix the date. But the issue is that highlight those points that must do know. I shared many material, but it doesn't mean that you have to read all. Every day I'll tell this word again. Because why? In exam, you have to make sure your conception are clear. In recall, they make wrong, but you are a doctor, you can't do wrong. Atrial fibrillation, heart failure, how you will manage the rate if you mark beta blockers, so mean you don't know anything. If you mark digoxin, that means you are excellent doctor. You know how to manage rate in the heart failure patient. So that is the way and aim of my course. Those exam before my course, they can ask me personally, they can get me how to consider it is another way, 2 to 3 candidates. But my 30 plus candidates aim is to complete the course, keep with me, practice, not so emphasis on the protocol, make the basic knowledge to deal every kind of disease management. They will not never misguide you, but misguide you the recall. Because these are the recall. I am candidates, I am giving these are the question scenario, this way I did my exam, but it could be wrong. So everyday feedback, everyday experience sharing, yes, I will prefer it, but we have to make sure our everyday scenario must to be correct. Okay, so kindly mute the mic when enter my session. Cardiology session, it could be 2 to 3 session, and neurology also, but all will be complete within 45 days. Even if needed, 2 to 3 session will be the more. So I'm starting to the ECG session, arrhythmia session, and I'll take more session regarding the ECG value because currently and recently they are giving many picture related questions either from the ECG or gynecology, CTG interpretations, some carbuncle, some dermatology, all will be covered. So you have to make sure that you are the expert enough to deal this kind of question by this course. I will not tell every depth of the question, but I'll say what is the basic and how you have to mark correctly the question. That is my aim. VT, you have to know it's a VT. That's it. It's SVT, it's a SVT. It's atrial fibrillation, it's not atrial flutter. You have to know that. That is my point. You are not a cardiologist, you are not a neurologist, but you have to know how to manage stroke, how to manage paresthesia. It means we are as a GP doctor, we have to manage basic disease. Okay. So I have to make sure the main steps of management, main clean cut scenario. Okay. So I'm starting my session. In ECG pictures, nowadays we know very well the ECG. They are in ECG interpretation. Question will be the either rate will be the irregular, so it's atrial fibrillation, rate and rhythm. Rate and a rhythm. Rate means what? Higher rate but rhythm irregular. P value. In every ECG, PQRST means SA node transferring the sinus node and the atrial activity, or you can say electrical activity, to the ventricle, and there's SA node, AV node, bundle bunch, and Purkinje fiber. So these are the pathway. If any pathway in this pathway anywhere rhythm disturbance or electrical impulse abnormality like AV nodal delay. AV nodal delay means what? Means AV node not working properly. It not transferring the impulse to the bundle branch to transmit this impulse to contract the cardiac muscle. SA node abnormality means P wave not working, and P wave abnormality means SA node dysfunction. We say sick sinus syndrome. SA node dysfunction. Kindly mute the mic, my dear candidates. Who joined? Can you mute the mics? So, WPW syndrome, slurred ST wave. Why? This wave due to accessory pathway of Purkinje fiber. There will be the it's a congenitally accessory pathway. That's why it develop up slurred obstruct volume in the ST wave. So PQRST, kindly mute the mic, doctors. These are the value we know very well. When ST depression, it means ischemia. If tall T, it means hyperkalemia. If UF present, it means hypothermia. If QRS complex narrow, it means SVT. If QRS complex wide, it means ventricular tachycardia. We have to know the ECG. We have to know the management. So now the ECG interpretation. We know very well normal adult ECG. PQRST, there will be the P wave means SA node working, QRS complex ventricular depolarization, and T wave means it's a sinus rhythm. There's no disturbance. If you see this lead, and even exam, they give a normal ECG and they say what is the diagnosis. So see, there is no abnormality anywhere. No ST depression, no T inversion, no QT prolong or nothing. All are normal. Rhythm regular, irregular. Regular means sinus. SA not working well, P wave present is sinus. But rate and rhythm okay, but P wave not present. Rate okay, 70. Rhythm regular means sinus rhythm, but P wave not present. What is the diagnosis? Rhythm regular, rate normal, but P wave absent. What is the diagnosis?
Sick sinus syndrome.
No. Junctional rhythm. P wave absent is a junctional rhythm. Sick sinus syndrome presentation will be another way. There will be the drop beat or missing of the full complex. And pause, long pause. SA note not working. But here QRS complex here, but only P not here. It's not properly not working. It could be an electrolyte imbalance. That's why junctional arrhythmia ongoing. It is not an arrhythmia. It's a junctional property, junctional disturbance. Irregular rhythm. Irregular rhythm question, everyday coming question in the DHA had. Another question, actually when I discuss many question, many discussion, every day my many candidates messaging me. Practice, practice, practice. No one can do only 10 days practice and you can pass. Never possible. Never possible. You have to be dedicated. You have to be practice more and you have to clear your conception to ace the exam. Many candidates ongoing my course and they always on my course. Why? Not to miss any question, any discussion. That is the point. Here in even in this course also, many candidates from my previous course, they don't want to miss any discussion. That is the excellent. Okay. So my intention to do regarding the junctional to see P wave absent but QRS normal, P wave absent but QRS the rate rhythm, all are okay, but it's a junctional due to electrolyte imbalance. Irregular rate, irregular rhythm. What is rate rhythm? Rate means what? Irregular rhythm means there is a rhythm disturbance. P wave absent and QRS complex not regular. QRS complex RR interval not regular. It's irregular. That means this rhythm can cause clot formation over the blood and it's an increased risk factor for the stroke, increased risk factor for the embolism, increased risk factor for the venous thromboembolism. So we have to make sure, is it paroxysmal? Is it permanent? Is it persistent? What kind of atrial fibrillation ongoing? Clear cut question in the exam. Patient known case of the chronic atrial fibrillation. Either they'll give how you will anticoagulant means patient INR 7. Now you have to make sure to prevent the bleeding. You have to give the antidote. Or they'll give patient still didn't get any warfarin because Chadha score 0. But now recently diagnosed as diabetes mellitus or recently have a stroke. So you have to add warfarin. Chadha score you have to know. AF question, very important question. You have to make sure your conception is clear. So for the ECG, I'm discussing the see the sinus rhythm complex. All are the sinus. Okay. And junctional, as I said, junctional said you see RR regular but no P, no P wave, nothing. Regular, red good, but no P wave. So it's a junctional rhythm. Okay. This is not our headache because junctional rhythm ECG they will not give. Our headache regarding the atrial fibrillation. P will not be present in the atrial fibrillation. So see the atrial fibrillation ECG. They can ask directly what is the diagnosis or they ask how you will manage the case. If they ask how you will manage the case, now I am giving a scenario. This question will be discussed with me, Dr. Saba. Dr. Saba is here.
Yes, ma'am, I'm here.
Okay. Dr. Saba, do you know Chadha score? Do you know Chadha score? Or I can show the images and I'll give you the scenario because this is very important question for your exam. Will I show the images or you start the question?
Okay, ma'am. Start the question.
Okay, start the question. Good. 68-year-old gentleman, diabetic, and history of transient ischemic attack 6 months back. Now present to your clinic with atrial fibrillation and you done a ECG. ECG revealed atrial fibrillation with 100 beat per minute. How you will manage? I will not give you option. You will tell me your answer. 68-year-old gentleman, diabetic mellitus and history of transient ischemic attack 6 months back. Recently come to your hospital with palpitation. You done ECG that reveal atrial fibrillation in which heart rate 100 beat per minute and BP stable. How you will manage?
Ma'am, with the pacemaker implantation,
Okay. What is the role of pacemaker? What happened here?
it will regulate the heartbeat. So we can manage this patient with the pacemaker implantation.
Only patient present to your hospital with atrial fibrillation. I said that you may not know the Chadva score. So if anyone know the Chadva score, I will share the Chadva score. Better to share the Chadva score. Dr. Saba, you will be here and I'll discuss this question with you.
Okay, ma'am.
Chadva score, when this scenario come to your exam, my MOS candidates basically I'm telling, though hard candidates may face and DHA candidates they give clean cut scenario, just they ask how you'll manage this question. I said 68-year old gentleman come to your hospital means Chadva score 1, age 68. You have to strongly memorize this score. Even I face on my exam. Okay. So 68 means score 1. Chadva score, I am spelling that heart failure mark will be the 1, hypertension marking. If I say patient is diabetic hypertension, so mean diabetes is 1, hypertension is 1, 1. So will be 1 plus 1 plus 1. So here there is no hypertension, so 1 only for the diabetes mellitus, 1 only for my age. Second, I said 6 months back history of transient ischemic attack. Vascular disease. Okay. Vascular disease score 1. But if I said patient have a stroke 6 months back, you have to mark 2. But I said it was transient ischemic attack, so score 1. So my score is total 3. I said how you will manage. Dr. Sabak, listen carefully. I said how you will manage mean my Chadva score is 3. So I have to start immediately because when I will start the DOAC NOAC warfarin, if Chadva score equal or more than 2 for the male or equal or more than 3 for the female. But remember very well, I will not maintain this chart. I will maintain this chart. Very carefully, if a male patient come to my hospital with Chadva score more than 1 or equal 1, male patient 1 or equal 1, I have to start warfarin, or you can write down the note. If 1 or more than 1, I have to start warfarin or DOAC or NOAC, apixaban, rivaroxaban, okay, rivarox. If female patient female patient come to my hospital. If female with atrial fibrillation is the sex itself score 1, female case, female patient. But for the male, he will not get a score 1, no. But for female, she will get score 1. Okay. For the female, if score more than 2 or equal to, for the female more than 2 or equal to, we have to start NOAC, DUAC or warfarin. Nowadays, warfarin we do not use. Because why? There is a hazards of doing INR every day or weekly to check what about the INR level. But recently, worldwide we use NOAC. There is no hazards for doing or checking INR level, PT level, thrombotic ratio, no need. It's safe. But though they are not using, remember, we can use warfarin, but nowadays DUAC use rivaroxaban, apixaban, these are the drugs. So, Dr. Saba, my question was your 68-year-old gentleman diabetic, history of thalassemia at a 6 months back, now palpitation, you done ECG, how you will manage, Dr. Saba?
Ma'am, start with the warfarin
To prevent
to prevent
risk
stroke.
of stroke. As patient high risk of stroke, already he has stroke 6 months back. Mini stroke, layman term. This same question always they come, but you have to make sure you are expert enough regarding the Chadva score. Okay, Dr. Saba? And
Okay,
you were telling that, ma'am, I will do pacemaker. How? It is not a complete heart block. It is not a junctional bradycardia is ongoing patient asystole. I have to make sure the sinus rhythm or 6 sinus rhythm, patient heart sudden syncope, and we done Holter monitoring and it shows 6 sinus syndrome. I have to make the pacemaker, nothing. No
Okay, ma'am.
words I said. Clear?
Yes, ma'am.
I feel all are clear. So my the ECG interpretation.
Yes, ma'am.
So atrial fibrillation, I'm short as the ECG few slides. That's why just make sure atrial fibrillation, the rhythm will be the irregular, but in atrial flutter there will be the sawtooth appearance. There is a sawtooth appearance. So flutter and fibrillation is not same. Why? There will be the sawtooth appearance. Okay, there will be the sawtooth appearance in flutter, and in fibrillation, there will be the rhythm will be the irregular. So we have to make sure this. Wolff Parkinson White syndrome. Just I'm making sure for my exam candidates, many 3 to 4 exam candidates very near exam. Just make sure because they give a ECG and we have to make sure that yeah, I understand it's a WPW syndrome. So WPW syndrome ECG, what is that? Anyone can tell me this is the ECG and anyone can describe. Dr. Maha Umar is here.
yes, ma'am.
Dr. Maha Umar, tell me
Ma'am.
these are the WPW syndrome and this is the ECG picture in your exam. So tell me what you are seeing in the ECG value. Just tell me rate, rhythm and the complex value. What you are seeing.
Ma'am, rate is regular
Okay,
and
excellent. Rate is
rhythm is also
regular.
regular.
Rhythm, there is no change of the
Rhythm. Yes, ma'am. R
so
interval.
rhythm.
Ma'am, rhythm is regular.
Regular. Rate is regular. Rhythm is regular. And rate almost.
Regular, madam.
Almost how
R
many?
uh,
Almost 100.
100, madam.
Right?
Yes, madam. Ji,
So
madam.
one thing, Dr. Maha, just 1 minute, I'm telling another shortest tips. When you want to calculate the rate, just make sure this first square will be the 300, second
Ji, madam.
square will be the 150, third
Mhm.
square will be the 100. This is the formula. 300, 150
150,
and 100.
100,
So what is the rate?
100, 100 per minute.
100. So another, why WPW? What happened here?
Mm, No idea, ma'am.
Anyone?
Ma'am, presence of delta wave.
Delta wave.
Um,
Delta wave. Where is delta?
Ma'am, at the beginning of when the QRS starts, actually
They
it
call
starts.
slurred upstroke volume. This is the slurred upstroke, right?
Yes, ma'am. Yes, ma'am.
Slurred upstroke. Dr. Maha, clear? These are the rate you see. P, then this is a slurred upstroke. So this indicate there is the accessory pathway in my cardiac rotation. Okay, so
Yes,
these are
madam.
this upstroke value. It indicates WPW
W
syndrome.
syndrome.
Okay,
Yes,
clear?
madam. Yes, madam.
Straightforward question, straightforward ECG they give, and they ask what is the diagnosis. If you say it's a sinus tachycardia or sinus rhythm, you will got wrong. That's it. My heart candidates, listen very carefully at your flatter so toothy parents, what WPW syndrome upstroke volume. Yes, and they will give nice picture in ECG. Nice picture in when you give exam in PC monitor computer, they'll give nice upstroke volume of the WPW syndrome. Thank you, Dr. Omer and Dr. Nandini, done very well. So AV block. Okay. Before that, ventricular tachycardia, ventricular fibrillation. Recent question, I shared ALS protocol, cardiac arrest, CPR value, and how we manage. Ventricular tachycardia and SVT, only one differential point. It's even myself, I don't like to do study more because why? I always want to concise the study. In which point I have to focus, that is. So ventricular tachycardia means QRS complex will be wider. Will be wider. What is the QRS value normally in sinus rhythm? It is the, if each square in ECG, there is a square, each square is 0.04. For QRS complex normal, it will be the within 3 small square. When it develop, it is within 3 small square means 0.12. But if supraventricular tachycardia develop, it below 3 small square, mean either it is within 2 small square. If you count 1 2, it means either within 2 small square or below 2 small square or within 1 small square. Supraventricular tachycardia below 3 small square or below 2 small square or only within 1 small square. You can count even. Ventricular tachycardia more than 3, 5, 6 like that. Management I'll discuss later. Now AV block. I'll discuss the AV block later. The heart or MI related heart attack or MI related complication. Some candidates like to read MTV step to SK or sometimes Kaplan. Actually, I don't want to read those so much because who's planned to give exam within 1 month and 1.5 months, do consult and listen my words very carefully. So it will be the shortened your notes. Yes, it's appreciating, do read, but for conciseness, do study my PDF first. So Mobis type 1 AV block, Mobis type 2 AV block, and third degree AV block. Mobis type 1 means PR interval more than 6, or you can say more than 5 small square. If you count 1, 2, 3, PR interval is normally till 4, I mean it is 0.02. It's a 0.04 is normal, but 0.20 means 5. PR interval is within 5 small square. If you count 1, 2, 3, 4, normally PR interval will be within 5 small square. If you see and if you count, it's a more than 5 small square. Means what? More than 0.20. It's a 3 or more than 6, 7, but it's constant. PR interval is constant, but it's prolonged. Means what? More than 6 small. Kindly mute the mic, candidates. So, when it is more than 5 small square, like 6 or 7, it is first degree AV block. PR interval more than 200 milliseconds as per my short word is more than 5 small square or 6 small square or 7 small square. If you count it 0.04, it means if it is 6, so it's a 0.24 small. 0.24 millisecond or more than 0.2 millisecond. That's it. This 200 millisecond or more than 0.2 millisecond. Mobis type when Quebec phenomenon, Mobis type 2. What is that? Mobis type 1 AV block is that after PQRS complex, the PR interval will be the lengthening. First of all, it will be the 6, then 7, then 8, then pause bit. Then again 6, 7, 8, then again pause bit. Okay. So Mobius type 1 and Mobius type 2, what I said, Mobius type 2, progressive lengthening of the PR interval, and that is the drop bit. Okay. Progressive lengthening PR interval, and that is a drop bit, is the Mobius type 2. So exam question related third degree complete heart block or Mobius type 2 AV block. They give this ECG in the exam and you have to interpret. So how to do this? Dr. Sajma is here. Okay. Dr. Fatima UAE.
Yes, ma'am.
Dr. Fatima, these are the ECG in your exam. Now tell me, what
Yes,
is
ma'am,
your
I'm here.
diagnosis? Dr. Sajma, okay, I'll ask you later. Dr. Fatima from UAE, you will discuss with me.
Okay.
Okay. From UAE, I is a heart candidate from the UAE.
Okay.
Mhm.
Mm, First
So,
one, the P.
yeah, this one, not it's a one. Your ECG exam a question is this one.
The second one.
Yeah.
Okay. The second one, the PR interval is 1, 2, 3. More than 6.
Just Dr. Fatima, normally, even if you don't know, just tell me this is the PQRS complex, right?
Yeah.
And normal PQRS complex, right?
Yes, ma'am.
There is no disturbance. PQRST, there's no disturbance. And second one is PQRS, right? No
Yeah.
disturbance.
Yeah.
Right or wrong? So one
Okay.
rhythm is good, second rhythm is good, and then there is a
There is
pause.
a pause.
There is a pause.
Yeah.
So what is that? What is the diagnosis?
There is a block.
Is it Mobius type 1? Is it Mobius type 2? Or it's a first degree?
I
No
don't know.
issue. We are here, we will do wrong and we will correct ourselves. This platform we will do more wrong and we will correct our question in the exam. Anyone? Okay, Dr. Fatima, I will discuss, no issue. Dr.
I
Afrin
couldn't
Keka,
understand, ma'am.
no issue. Dr. Madia Bhatia, I will ask Dr. Afrin Keka, recent exam candidates. Afrin Keka is here or not? Okay. Afrin Keka is not here. Dr. Ramzan is here or not?
Yes, ma'am. I'm here.
Okay. Dr. Ramzan, I should know that you already listened everything. Just tell me what is the diagnosis.
For the second picture, right, ma'am?
3, 1, 2, 3, 3 CG I'm discussing. And I already discussed with Dr. Fatima. I just want to know what is type of heart block it is. It's a 1, it's a 2,
Third picture,
it's a 3.
type 2, ma'am. Third picture.
Mobius type 2.
Yes, Hobbits type 2.
Mobius type 2 picture. Why? Because,
Because PR wave is same and there is dropped QRS.
yeah, good. Is it, can you tell me, is it 2:1 or 3:1? Just even if you do wrong, I'll never mind, cause is it 2:1 or 3:1?
Probably 2:1.
How? There's a two wave and there's a pause.
Yes.
So it's
Yes.
actually, this is not a 2:1. It is called 3:1. This is the value. Cause why? In exam, if each bit and if after this bit, this is the pause, then again one bit, then pause. So it is what type of block it is, Dr. Ramzan? Like I am telling Dr. Ramzan, this is that from here ECG started, and you see this is the one rhythm and this is the pause, and this is another rhythm and this is the pause. Is it 2:2 or 3:1? Exam scenario. What type of block it is? One rhythm pause, one rhythm pause. Is it 2:2
2
or
is to
3:2? It's a
2 is to
2:1.
2 is to 1.
So for this ECG, what type of block it is? 2:2 or 3:2? This tell me.
This is 3 is to 1.
This is 3:1. Right? Excellent,
Yes.
Dr. Ramzan. Thank you. Thank you. Excellent, you've done. So I already discussed regarding the Mobis step 1, Mobis step 2, and Mobis. And I'll discuss now third degree AV block. My one sentence I always say for complete heart block, they are dancing their rhythm. There is no relationship with each another. So what does it mean? They are dancing their rhythm means PQRS complex. This is the P, and there's no QRS, and there's a QRS, PQRS, that's a P, and that's not. So means what? PQRS, there's no relationship, nothing. They are dancing their own rhythm, means you are not getting any specific point. Clean cut ECG. You can't find it. Is it Mobis step 1? Is it Mobis step 2? Is it type 1 heart degree? Or is it complete? What is that? So when you count PR interval, when you count 2:1, it's a 3:1, but you are not getting any point. It means it's a complete heart block. So question recently, and I feel recent one recall I had given, second degree heart block associated inferior MI, and Dr. Somia or any candidate may ask how. Always inferior MI associated with complete heart block, but how second degree? They had given second degree heart block ECG. What you will do? I didn't post the ECG. I just sent the question. Even the recall, they didn't give the ECG, but they posted the ECG. But whatever the MI, they can cause any kind of arrhythmia. But I have to understand the ECG. Is it first degree? Is it second degree? Is it common? And you are reading the Kaplan, you are reading the MTV step 2 CK, and it's a crossly you are remembering, but you are doing wrong in the exam. Why? Because you just only blindly memorize, but you don't know anything. When they give Mobis step 2 or second degree heart block ECG after inferior MI, how it could be complete heart block? We commonly know inferior MI associated with complete heart block, but they only give 2:1 AV block ECG. So make sure you understand the ECG. Make sure the complication, it could be any kind of complication. I am reading Kaplan, I am the boss enough for the MTV. It doesn't mean you know anything, because you have to pass yourself in first attempt. That is my point of view. Okay. So as I discussed today, Mobis step 1, Wenkovic phenomenon, and Mobis step 2, and complete heart block, shortly remember this way. For the practice, my heart candidates, just Google them to see more images, and I already given some images, and it will be more updated gradually. Those images enough for the passing exam, enough. And already I start the summary of the ECG. So see, this is the first degree wave block, and I'll ask the question from the doctor. Dr. Rekha is here.
Yes, ma'am.
Dr. Rekha, why first degree, dear?
Why first degree? Because I think that is regular rhythm. Uh,
Any
uh, there
one
is
point,
no
just tell me.
missing.
Just one point, tell me, ma'am. This is the point for first degree AB block.
Uh, I think that is due to
What about the PR interval,
uh,
Dr. Rekha? As I
PR.
discussed
Yes,
regarding the
PR.
PR, yeah.
Yes,
What
yes, yes.
about that? Did
PR
you
interval
remember?
is yeah, it is more than 5.
More than excellent. So here,
Here it is
more than 5. If you count
more
1, 2,
than 5.
3, though, this if you count more than, if you count 1, 2, 3, it will be is if I count here now in exam, you can count. It's more than 5, so around 8. But another point, Dr. Rekha, it is constant,
Yes, yes, yes.
right?
It is more
It
than
is
5. Yeah,
constant.
I
It
got
is
it.
more
Ma'am.
than
Yes,
yeah, and it is constant. It is not
yes.
progressive, right?
Right, right. Yes.
Okay, okay, thank you. Dr. Hira is here.
Yes, ma'am.
Okay. Dr. Hira, type 1 secondary AB block means what? Actually, I forget what is mean. It is second degree AB block type 1. What is meaning?
Type 1 is Mobitz. Type 1 Mobitz. There is a prolonged PR interval, and the PR interval is prolonged. Then there is a drop beat.
Progressive lengthening, or it will be the constant? What is it?
It will be progressive, ma'am. I think so.
Progressive lengthening means what, Dr. Hira? Progressive lengthening is what, Dr. Hira? If you say, if I say, Dr. Hira, can you tell me what is progressive lengthening means? PR interval, then pause bit. What is that?
Ma'am, like their PR interval is prolonged. Then there is the QRS complex is there is no proper QRS complex.
No. Dr. Hira, shortly,
Yes.
second degree AB block or Mobius type 1 AB block means PR interval starting prolongation lengthening means here 3, now 5, now 8. Means what? It is lengthening.
Yeah. Okay,
Here
ma'am.
3,
Yeah.
here 6, here 8. Means it is
Yeah.
lengthening.
Okay.
Now it is pause bit. There is no lengthening, it's a pause bit.
Okay.
There is no complex. Then again 3, 6, 8, then pause bit.
Okay, ma'am.
It means it is second degree AV block.
Okay.
Okay, thank you.
Thank you so much, ma'am.
So another candidate I'm asking, Dr. Akinsiko Solomon. Try to be active in the Zoom session because Donilda is here.
Yes, ma'am. Yes, ma'am.
Dr. Donilda, excellent. So Dr. Donilda, can you tell me regarding type 2 second degree heart block, what type of heart block it is? Why type 2 second degree? What does it mean?
That PR RR interval is more lengthening, more RR interval. The and QRS is very small, so there is prolongation of.
Okay, Dr. Donald. Actually, sometimes I wrongly
It's
Donilda. Sorry.
okay. No, yeah.
So Dr.
It's okay.
Donilda. So see, PQRS complex, nice, right? There is no rhythm disturbance, and there is no beat here.
Okay.
Then again PQRS, then no beat here.
Yeah.
Is it 2:1 or 3:1?
I think it's 3:1.
How? Every one complex PQRS, one absent. I discussed with Dr. Ramzan what type of AV block it is. One complex, one mistake. One complex, one mistake. No issue, we'll discuss because I want to be make sure my candidates know everything. Dr. Madiha is here.
Yes, ma'am.
Dr. Madiha, tell me regarding the type 2 second degree AV block.
Type 2, Mobitz type 2. Okay, ma'am. It has fixed PR interval with a sudden drop beat.
Sudden, each compress then drop it, each compress then drop it.
Then drop beat.
What does it mean?
This is then type 2.
No, I mean, is it, I said, what type of block is it? Is it 4:1? Is it 1:1?
2
Is
is to
it
1.
it is 2:1? Why? After one complex, one drop bit. One complex,
Yes,
one
ma'am.
drop bit.
One drop beat.
Dr. Donilda, are you here?
Yes, 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 yes.
Dr.
Yes, ma'am.
Donilda,
Yes, ma'am.
remember strongly exam question. After each PQRS complex, each sinus rhythm, if there is a drop bit is 1, then drop bit
Yeah.
is a 2:1.
Okay, okay. Yeah, got it.
If after, like Dr. Ramzan and I discussed, if each two complex and one absent, two complex and one absent, what is that type of block? Two complex, then one phosphate. Two complex and one phosphate means it is 3:1.
3, yeah, okay.
Clear, Dr. Donilda?
Yeah, yeah. Okay.
Or
Okay, ma'am.
you want to see those ECG, Dr. Ramzan, we discuss. Yeah, see, Dr. Donilda, I feel you are not still confident. So see here, one complex and phosphate. What type of complex block it is? 2:1 or
2 is to,
3:1?
this is
No.
2:1.
How? I said after 2 bit 1 missing. It
Okay,
is
okay.
3:1.
3, okay, yeah. 3:1.
Clear?
Okay, yeah. Okay.
And in this area, what type of block it is? 2:1 or 3:1? Each complex, each miss bit. What type of block it is?
It's
Dr. Donilla?
2 is to
2:1.
1. 2 is to 1.
2:1. Yeah, 2:1. Excellent. Clear, right? Because these are the
Okay.
exam question. Okay, clear? No
Okay.
need to be misses. First degree, second degree, complete hard block they give, and whatever I read the MTB step 2, whatever the Kaplan I am expert, but I have to read the ECG. Because they give after AMI what type of ECG I have to read it. And I have to mark it. What is the answer it is. Okay? So when I marked the secondary AV block, they said it's a complete analysis, incomplete hard block. Yeah, we know, but they marked as a ECG value. So we have to mark it. Okay?
Okay.
Thank you, doctors. So I know my dear candidates know very well the AMI value. Dr. Kishore is here.
I'm here, ma'am.
Dr. Kishore, for you, can you tell me this ECG value? This one. What you are seeing here?
The lateral MI value?
The first one. First one ECG value. See and tell me first one ECG diagnosis. One and what you are seeing? Tell me, ma'am. I am seeing this, and this could be this, that is.
I can there. Okay. Is that ma'am, there is in lead like lead one, not lead one,
Okay.
lead
Lead
like
one. If
lead
you
one.
say lead one, what you are seeing? I tell me, ma'am. I am seeing this. Is there teen version? What you are seeing? Is there anything state depression? What you are seeing?
Ma'am, I'm seeing the lateral wall MI.
No. What it presents? What you are seeing? I am asking. ST,
Sorry, ma'am. I didn't.
ST elevation. In which leads they are? One AVL and V1 to V6 ST elevation. Dr. Kishori, right?
Lead 1 and lead AVL. Yes. Yes.
It's a lead
Is
1
that right?
ST up and one AVL ST up. You see here ST up.
Yes.
And V1 ST up, V2, V3, V4, V5, V6 all are ST up. So all reveals anterior
Interval.
extensive anterior MI or anterior myocardial infarction, right?
Yes, ma'am.
Clear? Any candidates have any question? We have to remember the leads. In lateral MI, one AVL. Okay? One AVL ST up. In anterior MI, V1 to V6 ST up and one AVL ST up. All together is anterior. Only one will altogether lateral MI, and they ask cardiology is not so easy. So we have to practice more. Enough my PDF, my lecture. Okay, though I'm giving PDF later because I have to ask and I have to discuss many questions, though this is the Eid time. So really very hard to take Eid time schedule, and after it there will be the roster schedule, all will be given tomorrow or day after tomorrow. So remember, anterior MI reveal one AVL along with V1 to V6, lateral MI reveal one AVL. Clear? Dr. Kishori?
Yes, ma'am. Ma'am,
Infra
one
MI.
question. Ma'am, suppose if there is anterior lateral wall, we go through lead V4 to V6 and lead 1 and lead AVL, right, ma'am?
V4 to V6, but V1 to V3, what happened?
V1 to
What happened? V3, what
V6?
happened? There is a lead V1 to V6. You tell me, ma'am, in my exam V4
Okay.
to V6 and one AVL. You asked me, right?
Yes, ma'am.
What your question? You asked me one AVL and V4 to V6. What kind of MI? You asked me.
Yes.
But my
Is
question,
this anterior lateral wall?
what about V1 to V3? What happened here? Always remember, Dr. Kishori and all candidates, anterior MI V1 to V6 along with one AVL. If only one AVL, it means it's a high lateral. One AVL is only a high lateral or lateral, but if they give only V1 to V4, it reveals anteroseptal. But anyway, they didn't give V1 to V3, only they give V4 to V6 along with one AVL. So it means it's anterior. Dr. Kishori, clear or not?
Yes, ma'am.
Any question? Second question, this ECG interpretation will be tell with me, Dr. Dr. Pallavi is here.
Yes, ma'am.
Do you know this ECG, what it reveals, what is the diagnosis?
ST depression.
Where depression, my dear? Tell me, these are the lead. Okay, AVL, ST depression. And
2, 3 ST elevation, I think.
2, 3 ST elevation and AVF.
AVF, yes.
So
AVF,
what does it
ST
mean?
ST elevated MI.
Yeah, is it anterior? Is it lateral?
Interior MI.
Inferior MI, excellent. Common question in the is the inferior MI. Every day these are questions coming DHA heart candidates every day. Inferior MI, anterior MI. Remember, Dr. Kishori 1 alveol V4 to V6, whatever they said. If they say V4 to V6 with 1 alveol, it's anterior. If they say V1 to V6 with 1 alveol, it's anterior. If they say only V1 to V6, only V1 to V4, it's anteroseptal. Clear?
Yes, ma'am.
Hyperkalemia, very. It's what I can say. It's a very important question. My heart candidates, they give this picture, they give the cardiac arrest question, how you will manage, or they ask what is the diagnosis here. Very important question, hyperkalemia. So remember, hyperkalemia question, tall peaked T wave, potassium value 6, potassium value more than 6, they ask how you will manage. Initially or definitive, I will discuss everything. So hyperkalemia picture, tall peak T wave, it leads to cardiac arrest. So it's a cardiac emergency. So this question they ask from the emergency part. So you have to make sure, yeah, I know very well. It's a T tall T wave, so it's a hyperkalemia, so I have to manage what they ask me. Remember this ECG very well, this hyperkalemia ECG. Hypokalemic ECG itself cause cardiac arrest. So hypokalemic ECG, we have to make sure this one, this J wave and this T inversion and atypical, they will give the potassium value and they'll give a bradycardia junctional rhythm. Junctional bradycardia. First of all, I discussed today from the ECG junctional. Only for the hypokalemia. Hypokalemia always junctional bradycardia. You see, there's no P. If sometimes there's P and sometimes inverted, you see there's a P is not nice. P is inverting, like this wave, inverting. So this P wave junctional rhythm for the hypokalemia, it itself causes cardiac arrest. Pericarditis question, typical question for the exam. They ask very well and they give scenario for the pericarditis and they give this ECG picture, ST elevation in all leads, 1, 2, 3, 4, every lead. ST elevation or saddle shape ST elevation in the pericarditis, it means it's a inflammation ongoing in the pericardium. So it's a pericarditis, okay? Inflammatory changes. So pericarditis ECG, these are the pericarditis ECG. So see, this 1, 2, 3, and V1 to V all are ST up. Is there any MI that all needs will be the high? No, no MI. Global elevation of the ST change only for the pericarditis. Okay. So my dear candidates, today I summarize the ECG. Okay. These are the very high yield example for the ECG: VT, SVT, atrial fibrillation, atrial flutter, myocardial infarction, pulmonary embolism, picture, ECG picture, S1, V3, Q3. This is the picture, but they don't ask. But if they ask, they will ask relevant value. So we have to know the management, how we will manage. So 2 to 3 topics we can discuss today from the cardiology. Already I end my ECG section. So we can practice few questions in the meantime. This will be better that we know very well. So, okay. So question 5 will be discussed. I'm asking few candidates whose exam very near. That's why. Its name Bizin is not here. So today candidate is not here. So this question will be performed with me, Dr. Reza.
Hi.
Yeah. The question 5 for you.
Okay. A 62 years old man has a routine ECG operatively for an elective orthostatic osteoarthritis of a knee replacement. He is in sinus rhythm, and the white PC complex is not prolonged. There is a gradual prolongation of the EPR interval followed by a dropped beat every 3 or 4 QRS complex. The ECG machine is unable to calculate the PR interval. The patient does not complain of any palpitations. What is a single most likely diagnosis? It will be heart block, and after 3 or 4 QRS, we have a drop beat. Then it must be type 2 heart block, movies 2, movies type 2 block. I think it will be D.
Dr. Reza, you see, they said one point strongly, gradual prolongation of PR interval. Is there any point did I say
Oh,
movies
okay.
type 2 block?
Movies type
Did I
2.
say?
Yeah.
Never.
Yeah.
No,
Yeah.
I discussed this question, this ECG with 3 candidates. Mobius type 2 is Dr. Donilda, maybe. I discussed with him, with her, and another candidates regarding the 2:1, 3:1, whatever that, and PR prolongation never here. Mobius
Yes.
type 2.
Yeah.
What type of block it is?
Then it will be movies type. Okay. And movies type.
It will be what? It will be what type of block?
It will be a gradual prolongation of PR interval. It will be movies type 2, movies type 2, 2.
Again 2.
Yeah.
What is the
Again,
answer?
excuse me, type 2 number 1, type 2 1.
I asked, is it A, B, C, D, E? What you will mark your exam?
Okay, it's not type 1, it's type 2. Okay, but in subcategory, it will be type 1.
So I
Number
say A.
the D. It's not complete heart block. It's not movie type 1. First degree heart block, sinus bradycardia. I think the answer is D.
Again, Dr. Reza doing mistake. Okay, Dr. Reza, hold. Dr. Rekha, would you like to
Ma'am.
discuss, or Dr. Yeah?
Yeah, it is, ma'am. I feel it is C because gradual
Prolongation.
progressive lengthening with
Lengthening.
1
Excellent.
minute. Yeah,
Yeah,
missing of
excellent. Gradual prolongation. Excellent, excellent.
thank
1
you, ma'am.
point only. Dr. Reza, for 45 minutes or more than 45 minutes, I'm discussing only with ECG, because I know everyone will do wrong. Because why? Because they are not understand what about the blockers. Mobius type 1 and 2. Mobius type 1 and 2. We have to understand what is Mobius type 1. What is Mobius type 2? And I discussed with Dr. Donila 3 times what is 2:1, and Dr. Ramdan nicely discussed with me what is 2:1. And 2:1, 3:1, there is no PR prolongation. No, just there is a small, nice rhythm, and there is a pause beat. There's a nice sinus rhythm, and there is a nice pause beat. That's it. If after 2 rhythm, 1 sinus pause beat, it's a 2:1 or 3:1. If 1 rhythm, 1 drop, it's a 2:1. But Mobius type 1 will be the prolongation. Dr. Reza. Chronically prolongation PR interval reveal Mobius type 1. We have to understand type 1 type. It's not first degree, because first degree AB block, always PR interval will be the prolong, but it will be the constant. Clean cut. It will be the more than 5 small square or 6 or 7, whatever the thing, it is constant. It is 8, 8, 8, 8. But for the Mobius type 1, it will be the gradually prolongation 6, 8, 6, 6, 7, 8, 5, 7, 7, like that way. Don't do mistake, my dear candidates, because these are the paid question in the exam. This platform we will discuss, we will do wrong, but not in the exam. Dr. Reza, clear or not?
Yeah, I understand. Thank you.
Okay. Thank you.
Ma'am,
Yeah.
like the previous question,
Yeah.
I want to ask, suppose, ma'am,
Mhm.
there the PR interval is gradually progressive, right?
Mhm.
If PR interval is gradually progressive, what happened to the RR interval, ma'am?
Are in regular.
Okay, okay.
Yeah. Regular. Dr. Kishori, for you, you see, movie step 1 here, PR interval prolongation, movie step 1, PR prolongation and RR regular, and here pause beat, that's why RR irregular. Till pause beat, it will be the regular. Till pause beat.
Okay, ma'am.
Okay?
Okay.
Okay, clear?
Yes, ma'am.
So here, movie step 2, there is a compress and there's a pause beat, so it's a 2:1. Till pause beat, it will be the regular. Okay? Clear? Till
Yes, ma'am.
pause beat.
Okay, ma'am.
Here you see, till pause beat, it is a regular rhythm.
Okay, ma'am. Till pause beat. Okay.
Yeah. So, management. I discussed already the small square is frequency, and for the movie step 1, it will be the more than 5 small square. First degree AV block, it could be asymptomatic, sometimes non required any management. Movie step 2 or complete heart block both require permanent pacemaker, that was Sabajesin. Remember, movie step 2 and complete heart block, always remember it need permanent pacemaker. Clear?
Yes, ma'am.
Okay. Atrial fibrillation, I discussed my first class regarding the rate control. Recently asking question I'll discuss regarding the heart failure. They like very much heart failure with atrial fibrillation. This question they're asking nowadays. So remember, atrial fibrillation question, rate control, always I have to highlight first line is beta blocker. Second line calcium channel blocker. If patient asthmatic, I can't give beta blocker. Patient asthmatic, I have to make sure verapamil or diltiazem. Digoxin when? If patient present to your hospital, atrial fibrillation with heart failure, you have to add digoxin. It will not be managed by beta blocker. This is the very important question for the exam. My DHA and recent candidates, remember this question. Digoxin if patient present to my hospital with heart failure. Atrial flutter, always do cardioversion. Hemodynamically unstable, we have to do cardiovert the patient. My dear candidates, cardioversion protocol, synchronized shock, unsynchronized shock. This will vary regarding the patient condition. I shortly give a note in my group, but it will be discussed regarding the ALS protocol and CPR when I'll discuss those parts. But straightforward, remember, if patient come to my hospital with atrial flutter, there is no beta blocker, there is no amiodarone, short give cardioversion. Just a few days back, one question, two way they ask, ventricular tachycardia question. How they ask? Ventricular tachycardia, they give the ECG and management. One ECG they give and patient was pulseless. Another candidate's face patient was with pulse. So patient if hemodynamically stable, we can give amiodarone, we can give pilocarpine, we can give magnesium sulfate. It's called PALM method. Amiodarone if patient is stable. If patient unstable, hemodynamically unstable, two way this question were asked. Do this cardioversion. My dear candidates who are very weak in the cardiology, just keep remember shortly. Short is the note. No need to, we are not cardiologists. We have to make sure the question in the exam is right. Okay. Even after if I get the job in emergency medical officer, they ask many questions. If you give your CV, if you have experience, they ask many questions. So make sure you are expert enough. There's many kind of candidates here. Some are special and they are doing many work, many branch, but who are willing to doing the work in the emergency. So make sure this. So immediate in case of stable patient, unstable patient is a cardioversion or ventricular fibrillation. Always VT goes towards the ventricular fibrillation. Always ventricular tachycardia goes towards the ventricular fibrillation. So we have to give the asynchronous defibrillation because patient collapse, unconscious, no pulse, nothing. I said always asynchronous or unsynchronous shock only for patient if unstable. If patient unstable, we have to give non-synchronous or asynchronous shock. Synchronous shock only if patient is stable, it is on R wave. BT ongoing, VF ongoing, but patient pulse palpable, we have to give synchronized shock. I give a short note in my group, or you can write down on your note. So, ventricular fibrillation is the most important shockable arrhythmia. Most important shockable arrhythmia. Hypokalemia itself, VT, I discussed before that. So I discussed already flutter, fibrillation, tachycardia. This ECG. Management. Atrial fibrillation, beta blocker, calcium channel blocker, high yield topics for the exam. They are asking nowadays heart failure related question, add digoxin. And Chadha score, we have to calculate the Chadha score. Atrial flutter, do cardioversion, ventricular tachycardia, if stable, if unstable, ventricular fibrillation, we have to do the defibrillation. Okay, and sinus bradycardia, we have to make sure the cause. Why bradycardia? It could be the normal athletic patient. Okay. WPW syndrome, delta wave, slurred upstroke wave, I already discussed. Okay. Congestive heart failure, they give many ways this kind of question. Patient come to your hospital with severe distress, saturation dropping, and there is a pulmonary edema picture, how you will manage. Always remember, my dear candidates, we have to make sure what they ask in my exam, initially, or definitive, or decreased mortality. 3 ways this question asked in the exam. First of all, chronic heart failure patient or sudden onset heart failure patient, if come to my emergency, I am emergency doctor. The question scenario you have to understand what are the pattern. Is it emergency? Is it initial or it is chronic clinic? I am a clinic doctor, I am a GP. What is the setting? If acute exacerbation of the LVF, we have to give diuretic furosemide first to decrease pulmonary edema initially. If they ask how you will decrease mortality, we have to add AC inhibitor. If they ask what is the role of aplerenone spironolactone aldosterone antagonist to improve potassium retention to decrease hypokalemia, cause furosemide itself cause hypokalemia, which leads to arrhythmia. So these are the way we have to stepwise management of the heart failure, furosemide, then AC inhibitor, we have to add beta blocker to control the rate, and spironolactone. Doctor, I am discussing one candidate because exam question. Dr. Ikra is here.
Yes, ma'am.
Okay. Dr. Ikra, I am asking a 66-year-old gentleman come to your hospital with heart failure.
Okay, ma'am.
and heart rate is 130. Heart rate is 130. You already started furosemide, but rate is not controlling. How you will manage? You can ask any information if you need.
A patient came to me with heart failure and I gave furosemide.
Mhm.
Rate is not controlling yet.
Mhm.
Ma'am,
Okay, I'm giving you option. Will you give AC inhibitor? Will you give digoxin? Will you give warfarin? Will you give beta blocker?
ma'am, digoxin.
Why? This is the point. That's why I'm discussing. Will you give AC inhibitor? Will you give beta blocker? Will you give digoxin? Will you give warfarin?
Ma'am, actually, I'm confused between the AC inhibitors or digoxin.
Patient come to your hospital with heart failure. Heart rate is not controlling. Is it AF or is it regular? You can ask me. I am telling doctor it is regular rhythm.
Okay. Then
Doctor, Dr. Pallavi.
give beta blockers.
Beta blocker. Beta blocker. Clean cut scenario. Two way this question work I'm recently. Clean cut scenario. Without AF give beta blocker. With AF give what? With AF what we have to give? Without AF you can mark or you can write in your note. With AF what I will give. Without AF what I will give.
With AF you have we can give digoxin and atrial fibrillation.
And without AF? Digoxin. Without AF is a beta blocker. So remember strongly or you can make down its notes because this is the exam question, okay? With AF digoxin for the heart failure. Without AF, and I am asking heart rate 130 is not controllable, give beta blocker. Patient is not on AF. Patient is not on AF. What is the role of digoxin here? So we have to make sure the beta blocker here. Thank you, my dear candidates.
Excuse me, ma'am, we cannot hear you. There is a lot of disturbance, ma'am.
Okay, mute the mic. I am discussing again. Question is with F without F. My scenario was 66-year old gentleman come to your hospital with heart failure. You given furosemide but rate is not controlled. Rate is 130, 140. How you will manage? Option over AC inhibitor, beta blocker, warfarin, digoxin. Some candidates mark digoxin. Why? There is no F. What is the role of digoxin here? Digoxin only if patient present to my hospital with AF with heart failure. Can you mark it or you can write down or you can make a note? With AF with heart failure, I have to control the rate by digoxin. Without AF only heart failure patient on tachycardia, we have to give beta blocker. Clear? Any question from anyone? Any question or any confusion? No, ma'am. So already discussed regarding the MI management, monotherapy, real and permanent primary kidney intervention. Already discussed. So cardiac arrest protocol already I share an image in my group. So cardiac arrest I will shortly discuss. patient develop asystole, pulseless and asystole. There is no cardiac rhythm. Shout, start CPR, unresponsiveness. Even after passing the DHA has whatever the exam, you have to give the ALS, BLS exam and the certificate you have to get. So, when you are seeing this unresponsiveness, that you have to make sure airway intubation, open airway, and we have to check the airway, and we have to keep the ventilation by ongoing CPR 30:2, 2 ventilation 30 CPR. We have to assess the rhythm if shockable. Patient ongoing VF every day who are working in the cardiology, ICU, emergency, if shockable rhythm. We have to give 150 to 350, 100 joule shock, but it is not reverted. Again start CPR, again start the shockable. It's a shockable. If it is non-shockable, patient assistant continue ongoing CPR. In exam, what they ask? Exam question regarding ongoing CPR patient assistant, what drug you will give? Make sure adrenaline, vasopressin, magnesium sulfate. We can give amiodarone, but adrenaline first or vasopressin first. For rhythm, to come back the rhythm, though we are giving the shock for revert the rhythm, but we have to make sure this medication on my hand, there is a medication tool, there is a cardiac arrest team, and these are the drug we have to on our hand, and we have our this shockable machine, all are here for manage the case. So causology, reversible causology, you can see it could be the hypoxia, any kind of trauma after EMA, any kind of arrhythmia, patient can develop asystole. Clear? Cardiac arrest protocol, ALS protocol, they ask only from the what are the ventilation mode 30:2. Another, it was 2015, it was 15:2. Now recently it converted to 30:2. Now the medication vasopressin, adrenaline, not amiodarone. We don't give amiodarone first. We have to make sure this vasopressin and adrenaline. Dresler syndrome, I discussed with Dr. Yesterday, Dr. Shuri maybe. Pericarditis presentation, pericardial rub, chest pain, okay, and there's ST, widespread ST elevation, saddle shape, the ECG already I showed, this pericarditis and management NSAIDs, okay. Left ventricular aneurysm after MI, post MI, if patient ECG showed persistent ST elevation, it means aneurysm develop on the left ventricle, which develop after post MI. Okay. Shortcut, only one question. Persistent ST elevation means it's not pericarditis. Persistent ST elevation means it's aneurysm. Pericarditis presentation will be the fever, inflammatory chest pain, ST elevation upward all over the chest lid. It's a concave saddle shaped chest like that way. But don't be mismatched with one another. Don't do. Because why? Saddle shape ST elevation, PR depression, it is the pericarditis. But for the aneurysm persistent ST elevation, the least which double MI, if it is enter MI, the aneurysm lead V1 to V6, it will be persistently ST up. Okay. Murmur question I will discuss later, but today I'll not able to finish my cardiology. Third session, last session from the cardiology, I'll cover everything. From the cardiology ventricular septal defect, just remember it can develop first week of the MI and it develop pansystolic murmur. Just remember pansystolic murmur for the ventricular septal defect and they need urgent surgical correction. Mitral regurgitation question after MI rupture of the papillary muscle, patient develop pansystolic murmur. So, my dear candidates, you can ask, ma'am, pansystolic murmur for MR, for VSD, how I can mark? You have to mark after MI, it can develop VSD, but common is common. VSD very rarely develop after MI, commonly develop after MI, MR due to rupture papillary. And this question is asked, what is the cause of developing mitral regurgitation due to the rupture papillary muscle? Patient develop hypertension, tachycardia, failure-like picture. We have to do echocardiography to check the valvular area. Okay. Okay. Symptomatic bradycardia, always drug of choice, atropine. If need, we can do TPM, temporary pacemaker, if needed. Temporary pacemaker, but remember, always symptomatic bradycardia, patient present to your hospital with syncope, and you are seeing there is a junctional bradycardia or whatever the cause, we have to make sure initially. Always, my dear candidates, many candidates are very well, but they are not catch the good except and right answer. How? Symptomatic bradycardia, they ask initially what you'll do. You are marking TPM, that means cross. Initially, I have to give atropine first. If they said definitive, then TPM. If bradycardia ongoing, or next step after atropine, what you will do next? TPM, temporary pacemaker, if it is not cardioverted or if it is not maintained. Hypertension, cardiac tamponade pictures trial I already discussed. So last topics today, infective endocarditis. Very important for the exam question regarding the antibiotic of choice. First of all, shortly I want to give the session from this way, and later the antibiotic prophylaxis I'll take the shortcutly another pages. So remember, last topic is infective endocarditis. Murmur, fever, patient come to your hospital. We have to make sure, is it prosthetic heart valve present, remote valve heart vessel, or previous? These are the risk factors for infective endocarditis. Patient come to my hospital with new murmur, with fever, and patient diagnosed as infective endocarditis. We have to do the echo, we have to do the blood culture. Rheumatic valve disease, prosthetic valve disease, congenital heart disease. Today, Dr. Reza may be asking subaortic stenosis they given, but it is not a risk factor for the infective endocarditis. Risk factor are here. Either rheumatic valve disease or congenital heart defect like VSD, PDA, ASD, or intravenous drug user, drug abuser, they are the risk. They are asking patient are aortic stenosis, and you are asking, ma'am, aortic stenosis. So yes, we have to keep careful. But if there is a patient of supraventricular obstruction, supraventricular obstruction, or patient have HOCM, is there any question they given HOCM or SBCO? No. We have to know the risk factor, and along with the risk factor, we have to make sure the antibiotic prophylaxis. The causative organism today, Dr. Hira may be asking, common is common. Within first month, if prosthetic valve implanted, and we have to make sure the endocarditis is due to Staphylococcus aureus. Prosthetic valve surgery If it is prosthetic valve surgery, the organism will be the epidermis, Streptococcus epidermis, after 1 month. But prosthetic valve, always just remember, or you can memorize that prosthetic valve is epidermis generally, or within 1 month of recent infection, it is due to the aureus. Viridans, it could be the commonest cause if patient dental hygiene not maintained. Okay. So management, so see, after culture sensitivity result, we have to give this penicillin, gentamicin, but remember, Staphylococcus and rickettsia. If Streptococcus, benzyl penicillin with gentamicin. If penicillin sensitive, so Venco and Genta. If Staph, flucloxacillin or vancomycin. Staphylococcus, both they give in the exam, not rickettsia commonly. Another question they ask, very rarely Pseudomonas, Genta and carbinacil. Another question they ask regarding the prosthetic valve VGR Manomix, Vanco, Genta, and rifampicin. VGR. That's it. 3 questions they ask. If it is Streptococcus, add penicillin in Genta. If penicillin sensitivity, add vancomycin Genta. If Staph aureus, add flucloxacillin or vancomycin. If it is prosthetic valve, add VGR. Clear? All my candidates? Any question, any query, anything from today's discussion? Tomorrow we'll be posting from the cardiology question and recall. Till Eid, inshallah, within few days of the Eid, I'll take the session soon. Due to the Ramadan Eid session, I'm taking the break, and within the break, there will be the always practice from the mock, recall, practice, whatever I question post, you will do practice. So, any question from the cardiology till now what I discussed today? Okay, so I think all are clear. So I'm ending my session. Assalamualaikum to all.
Assalamualaikum, madam.
Thank you,
Thank
ma'am.
you, ma'am.
Thank you, ma'am. Thank you so much, ma'am.
Thank you, ma'am.
Assalamualaikum warahmatullahi wabarakatuh.